Hello, ladies and gentlemen. This lecture in our ongoing series of lectures on anesthesiology is going to focus on anesthesia systems, the very important topic of airway management, and then briefly on monitoring in anesthesia. So we're going to talk a little bit about the anesthetic machine. We're going to talk about the partial rebreathing system, which is the standard by which most of us function nowadays. We're going to talk about the difficult airway, which I've had many sleepless nights worrying about this, and I know nearly all my colleagues have as well. And we're going to talk about standards of monitoring for the anesthesia patient. So we've gone from a very simple process of dropping ether onto what was called a Schimmelbusch mask and allowing it to vaporize as the patient breathed through the mask, to very sophisticated systems that are microprocessor based and are highly developed to primarily deliver safe amounts of anesthetic in an effective fashion. So this is the modern anesthetic machine. As you can see, it's a very complicated piece of equipment. Some people compare anesthesia to piloting a plane. This is our cockpit. In the anesthesia machine, there are many valves, there are many pipes, there's a high-pressure gas system, there's a low-pressure gas system, there are vaporizers, there are monitors, as you can see on the device, and on the right hand, on the pole that comes off the right-hand side of the device, you can see infusion pumps. Down in the lower part of the device where you can see pipes and the greenish colored bag, that's the circle system, and that's really what's responsible for our way of delivering anesthetics. There's many safety features built into an anesthetic machine, not the least of which is that it must be serviced at least annually, and the vapors are separately calibrated annually. The monitors have become part of the machine now. They used to be on separate poles, separate from the machine, and now they're really built into the machine. And when we buy an anesthetic machine, we nearly always buy new monitors at the same time. The principle of the modern anesthetic machine is that it is a partial rebreathing system. And what that means is that when the patient inspires oxygen, air, and anesthetic vapor, they don't use all of it. And in fact, as far as oxygen is concerned, it's said that the average 70 kilogram individual burns about 200 milliliters of oxygen a minute. So all we in theory have to do is deliver 200 milliliters of oxygen to the patient every minute. The only thing the patient does in response to this is produces carbon dioxide. We can't allow the patient to rebreathe the carbon dioxide because that would result in the respiratory acidosis we talked about earlier, would cause tremendous stimulation to ventilation, and in fact would make it almost impossible to safely anesthetize the patient. So we have to scrub the carbon dioxide out of the expired gases. And we do this by using Sodaline canisters. And you can see on this machine the two devices that are piled one on top of the other are Sodaline canisters. And fresh gas flow comes in from the bottom. Expired gas comes from the bag in the lower part of the diagram. And then as the bag is compressed, a combination of fresh gas and expired gas is forced up through the exchange material, and carbon dioxide is scrubbed out so that the material going to the patient is free of carbon dioxide. It has vapor in it. It has additional oxygen because most of us try to compensate for that 200 mils of oxygen that the average patient burns every minute by giving them something more than 200 mils. I, on average, give 400 mils at least per minute in a patient who's not otherwise requiring extra oxygen. So there's a safety margin that we all work with. The benefit of this kind of a system is that we don't waste a lot of materials. So patients expire unused vapor and inspire it again, which allows them to continue to remain anesthetized, even rebreathing the same anesthetic vapor repeatedly. They get rid of carbon dioxide with every breath, and they get new oxygen with every breath. The overall waste of gas is very low. So we're not venting gas to the vapor or to the atmosphere, particularly seeing that vapors do have some environmental risks associated with them. And we're also maintaining cost effectiveness by reducing the amount of vapor that we use overall. So the Sodaline canister, as I mentioned, scrubs the carbon dioxide out of the expired gas. So the expired gas on this slide is blue, and the fresh gas flow is red. So that fresh gas flow will consist of new vapor and oxygen and perhaps some air. The expired gas will consist of unused vapor, some unused oxygen, and carbon dioxide. All the gases go through the Sodaline canisters. The carbon dioxide is removed, and everything else goes back to the patient. So Sodaline consists of calcium hydroxide, about 75%, and water about 20%, sodium hydroxide about 3%, and potassium hydroxide about 1%. It's an exothermic reaction, so that when the gases pass through the Sodaline, heat is generated, plus water is created, so that in time the Sodaline becomes wet and warm, and as it becomes wetter and it absorbs more carbon dioxide, it becomes exhausted. And it has a color dye in it that changes color and warns the anesthesiologist that it's time to change the Sodaline. So the overall reaction, as I mentioned, is carbon dioxide plus calcium hydroxide leads to the formation of calcium carbonate and water and heat. Water, calcium carbonate, and heat collect in the sodium lime. The colored dye in the sodium lime, which changes color when the material is exhausted and indicates it's time to replace the Sodaline, shows up. The anesthesiologist hopefully notices it, and in addition, to the sodium lime changing color, the expired gases are being monitored, so it's possible to see, and inspired gases, it's possible to see if carbon dioxide is building up in the circuit and the patient is rebreathing carbon dioxide, which is a situation we simply can't allow to happen. Berylime is the same substance basically as Sodaline, except it uses barium hydroxide instead of calcium hydroxide in the granules. So similar systems exist in submarines, diving bells, and decompression chambers, but in nowhere near the finicityness that is apparent in the anesthetic machine. In those systems, they're just big blocks of berylime or Sodaline, and they're periodically checked to see if they're getting exhausted, but there's no effort to control flow through them or to control the amount of gas they're engaged with. So the overall reaction is heat produced by the scrubbing of expired gases may be sufficient to cause partial breakdown of sevoflurane with the release of a substance called compound A, which can cause kidney damage in rats. We actually don't know if this is a problem in humans, but the recommended flow through an anesthetic machine when using Sodaline is 2 to 3 liters of fresh gas per minute to maintain lower temperatures in the Sodaline. With desflurane, we can turn the total flow way down, and this actually results in desflurane being a very economic drug to use because we use so little of it per minute. Excess gases in the circuit are released through an adjustable valve mechanism and are scavenged to the outside atmosphere. As I already mentioned, there is some risk of environmental damage from vapors being scavenged in this way, so we try to keep the total amount being released into the atmosphere at a low level. Anesthesiology has become a very safe area of medical care. It's been noted that anesthesiology is one of the few medical specialties where there has been a dramatic improvement in patient safety over the years. The old days where people used to die from anesthetics are gone, happily. Nowadays, the actual incidence of people dying secondary to anesthesia is extraordinarily rare. Every anesthetic machine, like a modern aircraft, has many, many fail-safe devices attached to it. Included in these are the disconnect alarm, which alarms when it recognizes a decrease in system pressure, indicating the possibility of a system disconnect. In other words, the high-pressure gases that are entering the machine have somehow been cut off. Particularly if oxygen is cut off, this would mean that the major supply of oxygen to the machine was lost, and it's important that the machine lets you know when that happens. So there's a disconnect alarm. Vaporizer failures are almost unheard of nowadays because of the frequent checks that are done and recalibration that's done. And pressure limiters in the circuit prevent barotrauma or increased pressure damage to the lungs. High-pressure hoses, such as the supply hoses from the wall to the machine, are pin-indexed according to the gas they carry, so that they can only fit into certain connectors on the anesthetic machine, so that you don't have the risk of connecting an air hose or a nitrous oxide hose to the oxygen system in the machine. So in addition to the safety features I've already mentioned, all gas supplies that are connected to the anesthetic machine have agent-specific connectors. And vaporizers, which can run out of anesthetic liquid during an anesthetic and need to be refilled, can only be filled by the specific agent that they're designed to manage. The standing bellows in modern anesthetic machines minimizes the danger of incorrect gas flows. At one time, we had hanging bellows that could actually function in the absence of oxygen, and that was a major risk. Now they can't. Vaporizers that are positioned improperly, tilted, won't work. And pressure regulators in the machines are specific for each gas, reduce the gas pressure to an intermediate pressure within the machine, and then to a low pressure before gas gets to the patient. Pipeline and gas tank pressure gauges are prominently displayed on the machine within the view of the anesthesiologist. And in hospitals where there are big banks of gas cylinders or liquid oxygen containers, the equipment is checked daily. If there is an oxygen system failure, the machine continues to deliver air, which at least has 21% oxygen in it, to prevent hypoxemia. In other words, it's not really possible to inadvertently deliver 100% nitrous oxide, for instance, to a patient. And the oxygen flow meters are always positioned downstream from the nitrous oxide or airflow meters, so that a leak in a low-pressure system doesn't dilute the oxygen and result in a hypoxic breathing mixture. If there's a leak somewhere in the low-pressure system, the last thing that's affected is the oxygen, and the oxygen should be the dominant gas that's given to the patient even in that situation of a leak. The on-off knob on the oxygen flow meter is fluted and bigger than on the knobs in the nitrous oxide or air flow meters, so it's easy to feel even if you're not looking at it, although believe me, I'm not suggesting you don't look at it when you adjust it. The oxygen flow meter is made to disable the nitrous oxide flow meter if oxygen level is below 21%, or there's a failure in the oxygen system. So there's a continuous monitoring of inspired oxygen, and if it ever drops below 21% room air, the system automatically turns off any other gas that might be running, nitrous oxide or air. And a stiff button must be pushed on the vaporizer before vapor can be turned on. So there's either a catch that you compress with your fingers, or there's a button on the vaporizer dial that you have to push. And it's a bit of a push before you can turn it and change the vapor dose that you're providing. There's an interlock system which prevents more than one vaporizer from working at one time. So if you turn on the desflurane, you can't turn on the sevoflurane, and vice versa. And scavenging systems are set by international regulation, so we all have the same standards worldwide when it comes to scavenging systems. And an oxygen analyzer, low pressure analyzer, high pressure analyzer, and spirometer, which is a device for measuring breathing patterns, usually within the ventilator, are standard equipment on all anesthetic machines. So failure of anesthetic machines has become a very rare event. However, I'm aware of 2 events in my own hospital system in the last year that could have been disastrous. In one case, it was my own machine, and the entire breathing circuit and Sodaline canister fell off the machine, landed on my foot, which was not a pleasant experience, but more importantly, left me with no way to ventilate the patient or deliver vapors to the patient. I was able to quickly change over to a bag and mask system and start a propofol infusion, so no damage to the patient occurred, but it was certainly a scary event. And there's been some changes to that machine to try to prevent it again in the future. On another machine, a brand new machine, the amount of desflurane set by the anesthesiologist was initially supplied properly by the machine, and then for some reason, suddenly it stopped providing the dose that had been set. There was a dramatic drop in the amount of desflurane, and only the fact that the anesthesiologist was paying attention saved the patient from waking up in the middle of surgery. Those machines are now being evaluated to determine if there's an underlying system problem that needs to be fixed. So, all of the alarms we've talked about are on the anesthetic machines, and that's part of the standard monitoring system in an operating room. In addition to that, every patient gets an electrocardiogram. And most of us use a 5-lead electrocardiogram because this is a much more sensitive way of measuring for coronary ischemia, lack of oxygen supply to the heart, than just a 3-lead. We all use automatic and hopefully properly calibrated blood pressure cuffs. There's automatically on every patient an oxygen saturation monitor, an oximeter. The introduction of the oximeter in the late 1980s revolutionized the way we treat patients and improved care exponentially. On the machine, there's end-tidal carbon dioxide monitoring so that we always know that we're connected to the patient and that the patient is producing carbon dioxide. And it also allows us to adjust ventilation to make sure the carbon dioxide level is within what we consider to be a safe and normal range. We constantly monitor tidal volume and airway pressure through the machine as well. It's all done in every anesthetic machine virtually seamlessly. Then, at the discretion of the anesthesiologist, there are additional monitors that can be put in place. The peripheral nerve stimulator can monitor muscle relaxant status, and we can actually determine when it's possible to reverse a muscle relaxant by using this device. Or we can determine that maybe the surgeon's right, that the patient isn't adequately paralyzed, and it's time to give more muscle relaxant. Temperature monitoring is mandatory in the United States, but is immediately available in most places. Initially, it was introduced as a way to monitor for malignant hyperthermia, which we will talk about in more detail in a later lecture. But it turns out that temperature change is a late indicator of that disorder. So monitoring temperature for that disorder is probably not an important feature of temperature monitoring, but operating rooms tend to be cold and people lose heat in operating rooms. And there's danger in losing heat and becoming hypothermic. So most of us measure temperature on a regular basis as well. Modern anesthetic machines also tell us exactly how much vapor the patient is receiving on inspiration, and more importantly, from the perspective of knowing how deep our anesthetic is, shows us what their end-tidal vapor level is. So they're expired. When they expire vapor at the end of a breath, we know exactly how much is returning to the machine and whether the patient is retaining enough to maintain anesthesia. We also can use ultrasound transthoracically across the thoracic wall or transabdominally to look for evolving problems in the chest or in the abdomen. There are a number of invasive monitors that are used in specific procedures and for high-risk patients. So invasive monitors are any monitor in which we have to put a line into the patient in some fashion and then connect to one of these colored transducers outside the patient, and each of these transducers has to be calibrated at the time we connect it to the patient. And this allows us to measure the actual pressure the patient is generating. This can be blood pressure. This is a very common use of this, is we just place some freezing in the wrist and we pass a catheter into the radial artery and we connect the radial artery to a transducer and we can measure the actual blood pressure every time the patient's heart beats. Plus we can take blood samples without sticking more needles in the patient. But there are a lot of other pressures we also measure, including central venous pressure, which is the pressure of the venous blood within the body. We put a catheter through the internal jugular vein, usually into the superior vena cava or even into the right atrium, and we can measure pressures there. We can pass a catheter down through the heart, in through the tricuspid valve, out into the pulmonary circulation, and measure pressures in the lung. This kind of device can also measure cardiac output, can measure mixed venous saturation, which is an indication of oxygen use by the patient. Very sophisticated, very impressive, very helpful monitors. Patients who have intracranial hemorrhages or trauma to their head and have bleeding into their skull can have monitors placed that measure their intracranial pressure. So that kind of monitor is placed by a neurosurgeon, but we're the ones who hook it up and we often monitor it. In certain cardiac cases or in other cases where we're concerned about the patient's overall hemodynamic stability, we can pass a transesophageal echocardiogram through the esophagus of the patient, and we can do ultrasound from the esophagus through the heart anteriorly, and we can measure cardiac output, we can look at the actual contraction of the ventricle, and we can look at the function of the various cardiac valves. This is extremely valuable in cardiac surgery, but can also be used in other high-risk forms of surgery where the patient may be hemodynamically unstable. Sensory and motor evoked potentials are used in spinal cord surgery to make sure that nervous connections between the spine and the lower limbs don't get damaged during the surgery. Electroencephalogram is sometimes used in surgery. In one of the hospitals I work in, we use it all the time when we're doing carotid endarterectomies. In other words, cleaning out the carotid artery. We use an EEG to make sure that the patient's not having a decrease in the cerebral circulation, which might be a precursor to a stroke. In addition, there are new cerebral monitors. A very well-known one in the United States is the BIS monitor. It's not widely used elsewhere because it's actually never been shown to be very useful. But the BIS monitor is widely used in the United States and is supposed to be an indicator of depth of anesthesia and is supposed to help the anesthesiologist prevent recall during anesthesia. Cerebral oximetry monitoring actually allows us to look at the blood going into the brain and to determine its oxygen saturation. We can do fetal heart monitoring through the abdominal wall of the mother towards birth. And we do uterine contraction monitoring, particularly when we're doing emergency cesarean sections on patients who are in labor.